Welcome, everybody. I'm Michael Losoff. I'm the Director of Professional Development at Yellowbrick. You'll have to pardon me, this is my first time doing a webinar, so I'm not quite practiced yet in talking to a screen and not seeing other people. Anyways, welcome. And it's wonderful to get this Colleagues in Conversation series going again. It was something that we did fairly regularly before COVID, and then COVID hit and it slowed everybody down, of course. I mean, we're really pleased to get this going again. As we go into the summer, we have several planned going forward. I'll briefly introduce those. But as we go forward, we're hoping to get back, of course, to a point where we could do this live and in person. And if the CDC is nice to us, that might happen by the summer. We have a few of these planned. One coming up in about 5 or 6 weeks will be by Dr. Viner, a developmental neurobiological model of treatment in emerging adults. That'll be on June 22nd. We have one scheduled with Dr. Robert Gallitzer-Levy, psychotherapy with the adolescent brain. And then we're also working on a series on a Colleagues in Conversation to come up probably later in the summer and the fall about adoption, which is sort of an area of focus that we've been taking on here. Before I introduce Dr. Jaffe, just one practical matter. The washrooms are to the right and down. Oh, sorry. There's a way to ask questions. There's actually 2 ways to ask questions. One is through chat, and one is through Q&A. It's easier for us if you ask them through the Q&A function, although I will see both. But please ask your question through the QA. If you answer through chat, if you would send the question to me privately as opposed to the whole group, that would also be helpful and cut down on the noise on the screen. That said, I want to introduce Dr. Charles Jaffe, who's a training and supervising analyst at the Chicago Psychoanalytic Institute. He has taught courses in clinical practice, development, and theory at the Institute, and has conducted seminars and lectures in research and practice around the US and in China. He's received numerous awards for his teaching. His publications focus on psychoanalytic theory, adolescent development, the theory of therapeutic action, and the integration of clinical practice and research. As an aside, Dr. Jaffe has consulted with us in the past on cases here, and I think he brings a really deep understanding and a very accessible understanding of psychoanalysis. So I think you're in for a treat today. And with that, I'll turn it over to you, Charles.
Great, thank you very much. And first, I want to welcome all of you into my study. And I thank you for joining the conversation this evening. And many thanks to Jesse Viner and Yellowbrick, and to Erica Schmidt and the Chicago Psychoanalytic Institute for the invitation to speak about a topic that's truly dear to my heart. This day, I find it endlessly intriguing and truly humbling that 2 or more people can get together in a room armed only with conversation and emerge with a rich, textured, dynamic understanding of a person's emotions, their motives, their struggles and strengths, and then use that understanding to aid the person to alter both their behavior and their experience of themselves. Yes, it's true along the way, there can be tests and blood draws and imaging and various assigned activities, and we may talk about symptoms and relationships, past memories and trauma. But essentially, all this rich understanding blossoms in the context of people simply having a conversation with each other. After all, psychotherapy is, in its essence, just a special application of a conversation. And as such, people bring their full range of humanity into the room. And while that might not be the conscious focus of attention, it is nevertheless ever present, influencing each moment of every transaction. Now, I want to say at the start, I am not a neuroscientist. I'm a clinician interested in figuring out what we are doing when we do this thing that we do. I'm also a fan of making things operational and transparent rather than coded and arcane. I've long personally been uncomfortable with the sense that our clinical theory is incomplete. On the one hand, it is rich in classifying the phenomenon that we observe and in describing a developmental point of view that helps us make inferences about those observations. And yet at the same time, clinical theory is thin because the underlying problems that we have with metapsychology and in its failure to help understand this issue of what we are actually doing in the process of change. The concepts we usually use to explain what we are doing are inadequate. Transference, repetition compulsion, repression, regression, fixation, they're all useful descriptions of phenomenon, but they just don't address how it actually happens. Rather, psychoanalytic descriptions of how people change is always just a repetition of whatever theory is used to describe what went wrong with the first place. So we have words like synthetic function of the ego, optimal disillusionment within self-object stabilization, new object formation, and moments of meeting. They're all quite lovely within their framework, but frankly, they all sound more aspirational than operational. They're descriptions, but they don't really tell us what's going on. So tonight I'm inviting you to be excited about the continuing research that addresses this crucial question of what is happening when we search for the mind of another. I want to share my own journey to, as I said, kind of peek under the hood of our most commonplace daily clinical effort, searching to understand the inner experiences, meanings, and motivations of our patients. And like most learning journeys, my path has traveled from being puzzled and confused to the appearance of clarity, only to return to more confusion, puzzles, and appreciation of the complexity. So let's start with a slice of life. I'm going to ask you to take 2.5 minutes to look into the consulting room at two people in conversation. Specifically, you're going to see me and my patient. Don't worry, the patient gave full consent to the use of the material for research and teaching. This is not a case presentation. Instead, I invite you to just turn your attention to two people, one of them a Jewish psychiatrist on Michigan Avenue, and the other one a struggling African-American single mother, both of whom are having a conversation fully engaged and activated as they search to understand each other.
Yeah, but I do have something that I want to share with you. Last time I was here, we had talked about how people see me as a Black woman and, you know, worried about racism and whatever. Well, it was interesting because I think it was the next day or maybe 2 days after, I had an experience which was actually the contrary to what you were saying, with a neighbor who very much has a problem with who I am and who my children are. And yeah, that was really hard. And my son goes to school with the person across the street from this neighbor. And the little boy's parents, who are both white, actually came over to my house and had a conversation with me about it because this guy will no longer talk to them, let his kids play with them because their children play with mine.
Really?
Yeah. Yeah.
Yes.
And the two neighbors on the sides of them, I was the last of the 3 Black families that moved into the area. One's directly across the street from me. One's a couple houses down from this guy. And then I moved in. 2 people on this side told the people that my son plays with they were moving, putting their houses up for sale. That was enough. Right? Yeah. So that was kind of painful. I was just like, wow, okay. So I don't know how to filter that. I don't know what to do with that. Because that puts me right back in that how the world sees me.
Yeah.
So,
So when you say, you know, you wanted to let me know because it was really contrary, what do you want me to hear?
that maybe, I don't know, what I was thinking was right. But then but even still, it's not right, regardless of what they think.
That's right.
So what's happening in this conversation? What you see is two people acting with each other, behaving and searching. You can see that both of those folks are activated, a little bit uncomfortable, and exchanging more than just words alone. Empathic understanding, as I defined it, is actually action that constitutes a process of search that facilitates one person knowing the other ever more accurately, the meanings, motives, and behaviors. Empathic understanding is a reiterative, action-based, interactive exchange of a cognitive, affective, imaginative search for the fullest possible grasp of another's inner experience. This activity constitutes empathic understanding, and it is what powers psychotherapies. Alfred Margulies poetically described this deep knowledge as an inscape, that is, the landscape of another's inner world of emotions and meanings and mode of adaptation as they do life. I might modify that and call it an ecoscape, because it's not static, but rather a system that is at once stable and yet ever adapting to the internal and external environment. Now, we generally think of empathic understanding as useful or pro-social because we engage in this universal human behavior to help those who seek to achieve more flexible ranges of function and adaptation. But keep in mind, as we shall see later, this helping aspect is not built into the definition. So how have therapists understood the empathic process? We know that discussing empathy, or Einfühlung, as is the German word from which the English word is translated, it's tricky because it's been deployed in many areas in and beyond the mental health field. For analysts, empathy, like most clinical actions, has been defined within whatever is the preferred theoretical orientation of the user. Actually, our term empathy does a poor job of capturing the action sense of the German, which means feeling into, searching into, a term that includes both an affective and an action spatial sense. It's beyond the scope for tonight, but there are excellent reviews of this complex phenomenon within philosophy, psychoanalysis, and the body of empirical research. So let's start our look under the hood. What does a peek under the hood of the process look like? I'm going to start the discussion with a clinical view offered by Michael Bosch from Chicago and a dear mentor of mine in 1983. Bosch spent his career trying to make arcane psychoanalytic theory and concepts operational and in line with modern concepts of developmental brain and cognitive sciences. He was an early contributor to encouraging analysts to appreciate the biological processes that undergird empathic understanding. Using this clinical approach, I'm then going to take the parts of the process as he describes them and relate them to current trends in research. Hopefully by the end, we'll see how this peek under the hood helps raise important questions for our clinical theories and our work. I believe that Bosch's work is a good place to begin because it is familiar clinically and it presages an important line of empirical research that followed years later. So if you look at this chart, the actions that describe the search that constitutes empathic understanding can be viewed as a spiral that consists of three parts. The first is affective exchange. The second is interpretation of that affect in terms of the recipient's own meaning systems. The reason that it says open is just to indicate that the person is open to receiving and interpreting. And the third component is the comparison and contrast of one's own meaning systems with someone else's. When the cycle is repeated over and over and over and over again, the process gradually emerges as an increasingly precise understanding of the other individual. Now, affect resonance is a term to describe an immediate registration in one person of a communication that is received from another. Of note, Bosch used the work of Sylvan Tompkins, whose students included Paul Ekman and Cal Izzard. Tompkins was a researcher who, like others, developed a list of primary affects. His theory was that affect is an autonomic, non-conscious response triggered by the muscles of the face. Affect is registered in another through mimicry, much like the now familiar pictures of infants mimicking the facial expressions of actors after only a few hours of life. While we shall see that the understanding of these biological foundations of empathy have been greatly expanded over the last 40 years, this was the beginning of the effort to look at the biological core of the process, and a good way to think of it in simple terms. The second part, interpretation, or the third, means that the receiving individual first processes the affect in terms of what it means to the receiver. Received affect is registered in the context of that person's meaning systems for the experience. A meaning system that recruits far past and most recent history, physiology, and indeed the context of the immediate moment. In other words, and this is really important, the first interpretation is within the receiver's inner organization. Evaluation, or the third part of the cycle, is essentially just a process of comparing and contrasting individual meanings. One person communicates to the other, this is what this moment means to me. How does that compare with what it means to you? And that's kind of why I said to the patient, what do you want me to hear? Because I had a whole bunch of things that I was thinking about what she heard, but I didn't know what she meant. Of course, this is schematic. In fact, what can enter this cycle of search from any part in the spiral? It can be a bottom-up process of affect, meaning, and evaluation. It can also be a top-down process of a thought experiment, essentially saying, if I were you in your shoes, how might I feel? Frankly, as a student, I found this rather a relief, since for many at the time I was studying, the idea of empathy meant some kind of immediate ideal of profound emotional depth connection, a kind of perfect feeling mother, something that surely left me feeling inadequate. In his work, Bosch offered a developmental view of empathy. He suggested that we come into the world with inborn affects that communicate and amplify internal experience. With the development of language, these affects get symbolized into feelings, and still later, complex clusters of feelings are experienced as emotion. Finally, with the cognitive achievement of what Piaget called formal operations and the ability to decenter or think about thinking, mature empathy emerges with the ability to immerse ourselves in the experience of others without losing our own sense of a separate self. Again, an important piece we'll come back to. Needless to say, today we would use different words to describe the processes in empathic understanding and its development into a mature emotional competence. But these elements, affect resonance and the increasingly nuanced ability to feel with and into, that is perspective taking over developmental time, and then a capacity to use the experience for helping behavior are all contained in this initial offering. It's also important because, as we'll see, many people correctly assert that empathy is a more complex process than affect resonance or contagion alone. So this spiral is the process that moves human relationships in general and specific treatment along. This exchange constitutes, if you will, the fundamental unit of psychotherapy. One person says and does something, and the other one says and does something back. And most importantly, as these affective experiences are shared and clarified, these exchanges develop into the emergent understanding of another's deep world of meanings, motives in operation over time. So on the surface, this might sound mechanical, maybe even trivial, or a superficially conscious, rational level of discourse. Nothing would be farther from the truth of what is occurring. This curious search, or what I like to call informed naivete, presents an openness to many forms of responses through many modes of communication and levels of consciousness. You might have noticed that the patient and I had more than one exchange that was mainly nonverbal. To borrow from history, this is probably close to Freud's notion of freely hovering attention, Reich's metaphor of listening with the third ear, and even broadly speaking, the concept of neutrality. And in more contemporary terms, informed naivete also captures an essential foundation for improvisation, kind of an attitude of yes and that keeps an interaction open while no but quickly shuts it down. So of course, this is not a perfect system of a flowing spiral towards depth understanding. In fact, in the clinical setting, it's precisely the failures of the smooth operation of this search that have so much to offer in deepening our understanding of the other person. Rather than see these things as interferences or noise in the system, the messiness is the very root to deeper understanding. Psychoanalytically informed psychotherapists are, as a matter of course, constantly tracking this exchange, noting and repairing its disruptions in order to keep the flow moving forward, to move the patient towards new, more adaptive experiences and competencies. Let me elaborate this point just a little bit. If the patient in this chart cannot openly process affect, but instead encounters some significant interference with its meaning and reacts with anxiety or shame, then their attention will turn towards managing that active, painful experience and away from finishing the cycle, and that open will turn to close. We, of course, call that activity self-protection or generically defense. We also know that if the receiver has some neurocognitive problem with communicating or decoding affective signals, then of course that's going to lead to system failure. It's important to remember that the same thing can happen with the therapist. If the therapist can't process the other's responses because it activates too much psychic disruption, then again, a similar breakdown occurs. Psychodynamic clinical theory and theory of technique is rich with descriptions of these disruptions, hypotheses about their origins, and suggestions, and about techniques about how to address them. In fact, I would say the bulk of the rich and useful psychodynamic literature of theory and practice attends to observing and articulating the vicissitudes of these phenomena. They're the stuff of our nosology, our descriptions of the phenomenon of transference, countertrance, and enactments. The theories we use, from whatever biopsychosocial vantage point we choose, are simply the way we organize and classify either the positive or problematic occurrences within this conversation. They direct us to make appropriate choices in the array of possible interventions so that new experiences and interactions can occur. What does it actually feel like to be in this conversation? Nowadays, I think that most therapists consider the clinical process as akin to two or more people, in the case of couples and families, being kind of linked together by a climbing rope while ascending a mountain. One is the guide who's been there before, and the other or others is taking the journey for the first time. While from prior experience, the guide knows the general approach and routes toward the summit, at any given moment, the immediate conditions of terrain, weather, or personal distraction can mean that any of the participants has the best view of the next steps. And if one falls, everyone's impacted. In other words, therapists know a method and an approach and generally how to read the conditions, but they don't know exactly what will be encountered, and they certainly don't know how to intervene in advance. We have an exploratory method, and we know generally what can occur, but we begin the journey, we have no idea exactly what the contour of the landscape will be that we encounter. And that means we better come equipped with as many tools as we can to discern and then respond to the multiple eventualities. Sometimes I find myself saying to patients, you know, I'm not sure where we're going, but I think I know a few things about how to get there. Having set a model for the process, let's ask what we've learned about how these clinical conversations can occur between humans. Over the past number of decades, we've learned considerably more about the processes that underlie what we observe and live clinically. The findings can help us understand some of the challenges and questions left open with using our clinical knowledge alone. So let's take a look. We've become accustomed to placing our clinical work within a developmental frame. Classic theory used Freud's complementary series. Winnicott and more recently Bowlby, Ainsworth, Beebe, Stern, and a host of wonderful other people have advanced our view of development. And so we now accept that in the first moments of life, there are social emotional connections through affective imagery, gaze following, and other behaviors that occur between infants and caretakers. Current approaches in neuroscience take us even deeper, using complex dynamic systems as a frame of reference rather than the traditional developmental reductionist point of view. These approaches consider the nested interplay of microprocesses of fluid, asynchronous, reversible phenomenon and the emergent stable patterns that we think of as character, self, and self-esteem. Researchers are asking kind of questions like, what are the earliest minimal aspects of self? When is it possible to say that one person, no matter how young, can have a sense of the sense of another person? What forms and applications of empathy emerge from these processes? And on the clinical level, how can we understand these nested complex phenomenon in the people who arrive in our consultation rooms suffering from terribly painful feelings, relationships, and behaviors? So I want to give a quick word of warning as we pop the hood of empathic searching, that things are going to get a little bit complicated. As clinicians, we're operating at a high level of integration of many component parts. Researchers examine each one. To put it one way, it's a good thing to be a good driver and driving a car and know the feel of it. That's one good thing. But it's quite another thing to understand the electronics, physics, aerodynamics, and ergonomics that comprise your driving experience. I just put this slide up here. I'm not going to linger on it, but it's essentially a way of saying when we talk about neuroscience, neuroscience is composed of a number of research efforts. They're not all the same. They each have their own kinds of questions, their own methodology, and they have their own answers within their paradigms. And they sometimes, more often, hopefully than not, can begin to agree with each other. So let's take a look here at something. We'll start with something that you might be already rather familiar with. It's the area of study of the mirror neuron system, a neural network process that's referred to as embodied simulation. We all have experiences of feeling the joy, fear, and pain of others. We cringe at impending collisions, and we cry at the weddings, births, and tragedies of people that we don't know. Studies ask why we feel with others rather than simply observe them. And in a lab in Parma, Italy, in the early 1990s, researchers implanted probes in monkeys to study the motor system, and they discovered something quite remarkable. About 10% of the motor neurons that fired when the monkey took an action also fired when the animal observed someone take the same action. Essentially, the brain activation when observing mirrored the brain activation when doing the action. In other words, part of what happens when we observe an action is that we use our own bodies to map that action onto ourselves. Witnessing a motor action then elicits two kinds of information: the goal of the motor, the goal and the motor intention of the action. This is embodied simulation, and it actually creates the connection of our own experience to what we observe. It's a kind of very fundamental notion of it takes one to know one. From a developmental point of view, it's thought that infants, when, for example, they grasp, they're also experiencing, even watching themselves grasp in the motor, somatory, sensory, and visual areas of their brain. That is, they are creating embodied simulation maps of their own history which then consolidate in the familiar axiom of neurons that fire together, wire together, into memory systems that set the stage for future affect contagion. Of course, empathy is much more complex than embodied simulation alone. It also involves sharing emotions while recognizing that the emotions are indeed someone else's. This requires self-other differentiation in addition to affect contagion. It also involves perspective taking and tolerating the intensity of the embodied experience. So with a desire to listen and hopefully help rather than withdraw can occur. And we'll look more deeply into this shortly. Subsequent studies examine not only motor mirroring, but also sensory, and of special interest for our purposes, emotional simulation in embodied cognition. For example, to study the sensory system, the researchers would brush a subject's leg with a glove and then showed the subject movies of people being touched. This is all why somebody was in an fMRI machine. The brain activated regions were the same when being touched and when touching. To study emotion, researchers fitted a subject with an anesthesia mask, placed the subject in an fMRI scanner, and delivered a noxious odor. By the way, I gotta say, kudos to those brave volunteers for tolerating not only the noxious odor, but the experience of being in the scanner with an anesthesia mask on. Not for me. The subject, of course, registered disgust. Then the subject watched a movie of someone smelling a disgusting odor. And again, the same brain region responded. For a deeper exploration of this work, I invite all of you to visit Christian Kaiser's book, The Empathic Brain, or his wonderful lecture on YouTube. This chart just quickly illustrates the various regions of the brain. We're not going to have a deep dive into brain anatomy tonight, but just to give you a sense of it. As people act or observe in their moment-to-moment activities, all these regions are mapping and simulating the outside world and embodying it through interpersonal experience. The cortical areas involved are premotor, somatosensory, visual areas of the cortex, and the insula, which lies deeper in the brain. Taken together, they constitute a system to experience the world vicariously. The insula is of particular importance in this system because it is widely engaged in processing emotion and is thought to be involved in the integration of internal and external experience. The affect contagion research revealed some thought-provoking results for clinicians. For example, placing electrodes in rats revealed that when one rat received a mild shock and demonstrated a freeze response, the witnessing rat, there was another one looking, did not react if it had never been shocked, but it did freeze if it did. In other words, witnessing something utterly unfamiliar meant it had no salience and elicited no response. On the other hand, if there was prior experience, memory, then contagion occurred. Additionally, it was possibly to chemically block the mirroring pain reaction in the witnessing rat, revealing that even with prior experience, something could interrupt the experience from registering. Fast forward to people in our practice. It's good to remember that our patients, when they talk to us, are also hearing themselves. Not only are we simulating and either appreciating or blocking what we experience, so are they. Recall our description of the cycle of empathic understanding and how the system can be open, but it can also be blocked. Two other areas of work are worth noting here. First, in studying helping behavior, researchers discovered that most people are willing to give something up, like a payment in a social experiment, in order to relieve someone else's pain. The degree to which this occurs is a function of the intensity of the resonant affect. Witnessing more pain elicits more aid. However, again, it was possible to block the affect contagion reaction in the witness, resulting in a less nuanced, more generic, less attuned reaction. Second, interesting work with psychopaths revealed a much weaker response in the brain areas of embodied simulation. However, as you might expect, however, when they were instructed to try to empathize with others, their brains in the fMRI machine did in fact show a normal appearing response. In other words, they are not incapable, but they needed a reason to focus motivation. Ordinarily, we simply activate embodied simulation and on we go in an ongoing fashion. In psychopaths, these responses were activated to fill a motive. So these two areas of research are particularly evocative, I think, in our clinical work. First, the prosocial act of empathy varies according to the intensity of the affect contagion. If it's within a tolerable range, the desire to help can emerge. But if it's too intense, the behavior is actually aversive. This is a frequent finding in clinical work. When one person evokes an emotion in another that is too intense, that person can't respond to the pain of the other, but instead turns their attention to managing their internal distress. And thus, between the patient and therapist, we have the old axiom that if there are two people in the room, it's really best if one is less distressed than the other. Between couples, we also see that they have disruptions when painful current experiences and memory of one partner block that partner's ability to remain open and attuned to the other. And this often appears as a power struggle and gives rise to another therapeutic challenge. Would you rather be right or married? Furthermore, the study of psychopaths is a potent reminder that empathy is not intrinsically prosocial. It is a way of coming to understand the experience of another that in itself is neutral. It can be deployed for good or harm. So what about these emotions that get activated in simulation? Well, the simulation of motor, sensory, auditory, and visual areas is also connected to the emotion centers of the brain. We are all equipped with an inherited range of basic emotions that have provided us the fortunate evolutionary advantage of survival over the past 250 or so million years. The emotion systems can be thought of as biological imperatives for survival. For those of you who prefer it, these are the drives. Each one of them has a rudimentary reflexive response in the service of survival and maintaining emotional homeostasis. There have been a number of emotion systems offered, and in recent years, Jaques-Panksepp's classification using studies of non-human mammals has generally been accepted. And I'm just going to put this up for you to see. Each of these basic systems has a rudimentary action or reflex, an instinctual response, if you will, triggered by the activation of the emotion. These basic emotions are noted in capital letters to indicate, and this is important, that they are behavioral responses rather than subjective, emotional, self-reflective experiences. In fact, what they are is behaviors exhibited in rats when very specific areas of the brainstem are stimulated with probes. So, and each one has an instinctual reaction. So seeking creates foraging or searching. Rage, attack, fear, withdrawal, panic, grief, move closer, lust, mounting, care, aid, and play, reciprocal interactions. In the ordinary course of human development, of course, the straightforward expression of these emotions through their associated reflexes inevitably runs into the vicissitudes of life, including the world of other people. And this means that the infant needs to find ways to get their needs met within the context of the social surround. And life being what it is, the simple drive reflex actions do not result in immediate need satisfaction or return to some homeostatic balance. As a result, the child has to develop new and different strategies to navigate the world. Our various theories of human development simply track this progression. In addition, various emotional systems are activated simultaneously and often, like kind of bumping cars, present conflicts with each other. For example, rage may interfere with panic grief, or fear may compete with play. Again, the story of psychological development traces the vicissitudes of the epigenetic hierarchical emergence of these systems. On the right column, you'll just see these highly cognized human variants, just suggest the way humans express these basic emotions when they are encountered in a kind of tertiary fashion through experience and social learning. Since we're all equipped with the same basic emotional systems, it follows that they are in play in both of us, or all of us, when we're in the room with our patients. It's not hard to imagine then that the plot thickens quickly in such an encounter. Each of us come to the conversation with our own histories of navigating the world, of needs, frustrations, and adaptive strategies. Then all of this gets activated in the context of the interactions that occur in this conversation. In short, to the extent that embodied simulation occurs, what is embodied are cortical maps, the mirror neuron system, if you will, that formed in the context of the basic subcortical emotion systems. In the clinical conversation, we are resonating with the other person in the context of the immediate maps we bring that have been forged in the history of our life experience. We witness the other's actions, and that activates our sense of the other's goals and intentions. And we interpret them then in the context of our emotional experiences of similar goals and intentions. I want to say a word in particular about two of these basic emotion systems, seeking and play, as they pertain to the process of empathic understanding. Jaak Panksepp tells us that seeking is a general purpose, appetitive motivational system that is essential for animals to acquire all kinds of resource needs for survival, and probably helps most other emotion systems operate effectively. Seeking motivates the mind with curiosity and promotes a sense of engaged purpose. Regarding play, the function of play is to learn social rules and refine social interactions. Play urges are likely involved in the construction of higher social brain functions, including empathy. An important aspect of play is turn-taking. Back and forth, rough and tumble play in mammals works best if there is a significant reciprocity, about 60-40. While it is about dominance, too much destroys the improvisational opportunities for new experiences. So we can see that these two elements, play and seeking, are intrinsic to the back and forth, improvisational, reiterative, ongoing nature of the search of the empathic spiral. Together, they power the process. And in that process, appreciate one person's perspective and of another. So this brings us to the next place. Beyond affective resonance, we are clinically engaged in two processes. What does the affect mean to me? And if it means that to me, what might it mean to you? So let's take a look at that from social and affective neuroscience. We're all familiar with the concept that the therapist is a participant observer in the clinical conversation. This involves a balance of immersion, that is participating with the fullness of our being, and observer, an attitude of reflecting or watching, or me immersed with you, immersed with me, immersed with you. We clinically know that too much immersion without reflection is manifested by disruptions in the process, and too little leaves the process merely an intellectual exercise. Social neuroscientists state these issues in terms of self-other overlap, shared representations, perspective taking, and the ability to regulate cognitive and emotional processes. So what you see here is that not every instance or form of empathy can achieve the desired outcome of immersion and aid. A number of factors are at play beyond affect contagion that manifest in a range of empathic states. A number of factors are at play. The subject experience of empathy is more likely to occur if, one, the observer has previously experienced a related state. Two, the other state is highly meaningful or salient to the observer. Three, the observer has a strong or recent affected memory of the other state. And four, that there's time to reflect on the other state and there are no competing goals or distractions, like the observer is not too distressed to tolerate it. Clinically, we can say that at the extremes, the elements for a successful process of empathic understanding are derailed in one of two circumstances that kind of occur at the edge of a spectrum. At one end, derailment occurs because of inadequate shared experience or a lack of affective activation. Recall that the rat with no experience did not respond to the shock in the other. On the other end of the spectrum, the process can be derailed when the salient common experience is simply too intense, overstimulating, and interferes with self-regulation and self-reflection, and that leads to self-focus or withdrawal. In such cases, the need for self-other differentiation may in fact be threatened. Such conditions have clinical relevance. For example, we do see some patients wherein a process ensues in which we have an experience of, quote, losing our minds. We begin to believe that the attributions of the patient about us, pretty much all intensively negative and threatening, are in fact true, beyond our understanding of our ordinary mishigas. It is one of the most unnerving felt characteristics of what we call projective identification. And I'll return to this as we explore this very phenomenon as it relates to self-ownership. Within the extremes, then, there are a number of conditions that allow a process to proceed, and each carries its own vicissitudes. First thing to be failures of accurate empathic understanding because the participants appraise the communications differently. Clinically, this means that events discussed in treatment may be similar for both parties, but each person has their own history of idiosyncratic meanings and dispositions. And as we know, individual appraisals and responses and events, people use different words and they vary widely. Related to this, each person is affected by the other's style of communication. Commonly, this means that people express themselves through the veil of shame and guilt or via illusions and action rather than self-reflective discursive speech. In other words, obliquely. This arena where the conversation and search for empathic understanding reveals variations in idiosyncratic meaning systems that individuals develop over a lifespan actually is the main domain of psychoanalytically informed psychotherapy. It reminds us that empathic understanding is an action, and it has to occur to explore these personal differences in order to clarify the idiosyncratic meaning systems that can lead to more accurate understanding, which keeps the system open. It's also interesting that while there's a lot in the literature about affect contagion as the beginning of the process of the affect search, there's also evidence from research that this is not the only route into the system. As I mentioned earlier, for those of us with a more intellectual bent, this is a relief in a world where feeling with our patients is so valued. The evidence is that affective resonance or contagion need not start the process of the spiral. Preston describes it this way. If the observer can relate to the other's state, then personal and hypothetical imagery produce a peripheral response, an emotional reaction, with changes in heart rate, skin conduction, and facial muscular activity. But when the observer can't relate, they can still activate common neural representations, but do not experience the same downstream or emotional feelings. Instead, they recruit a region in the visual association cortex that presumably helps to try on the other state via more concrete visual images. Again, we can see that in the clinical encounter, while there may not be an initial richly textured recognition of the other's experience, the process may still move forward with what is essentially a thought experiment. It's this exchange, the evaluation phase of the empathic cycle, that helps the dynamic process remain open. One more empirical finding seems relevant for understanding how empathic understanding drives the process towards change. These studies reveal that empathic understanding is not synonymous with helping, altruism, or sympathy. Sympathy occurs when one pair is vulnerable, activating a nurturing response. The neural substrates of empathy actually don't overlap completely with sympathy. or active altruism, because empathy doesn't have to engage the neural circuits for offspring care in the same way that sympathy and altruism do. It's Panksepp's caring system. The urge to help an imperiled target may reflect an ancient neural system designed for offspring care, as Panksepp describes. According to this caregiving model of altruism, both empathy and active caregiving require attention and understanding, but only the caregiving response to an imperiled target requires this motivation, neurohormonal state, and downstream activating response. So actually, affect contagion is necessary but not sufficient for sympathetic helping behavior. I'm going to kind of go through this slide very quickly. This is just a graphic representation of basically everything I've said. That at the bottom, there are the way the brain operates with widely distributed parallel processing of neural networks. They emerge into cortical and subcortical regions, which is the domain of the basic affects. It's the domain of neural level self-other overlap or affect contagion. At a higher level of organization, those are processed in terms of salience, intensity, or level of meaning. Then we enter our level, which is two people talking to each other. And those operate with variable levels of consciousness, self-regulation, self-reflection, and plus or minus pro-social behavior. If all goes well, that's the empathic spiral, and out of that emerges yet new forms of adaptation and experience. So I want to look at one more approach to the issue of my immersion into your experience, while at the same time, hopefully holding on to my experience of me, you, and the separateness of you and me. This approach asks questions about the very nature of self. In this sense, this line of investigation takes the observations that we've talked about so far to yet another level. We saw that the various stable states contributed to various empathic forms, but new questions ask, how do we maintain self-continuity in the face of continuous interactions with others and the world around us at all? In fact, how do we know we are indeed even in our own bodies? What are the brain processes that underlie our subjective experience of body ownership and self? What factors relate to the stability and malleability of our experience of self and self in relation to other people? Such investigations revolve around the issue of multisensory integration and what happens when the brain is challenged in this regard. As a quick introduction, I was in my kitchen the other day looking out the window. I had just started running the dishwasher and I was standing next to it. I heard the gentle sound of water movement, and at the same time, I saw that the back walkway was wet, the sky was gray, and I felt the chilly dampness in the air. For a moment, I could have sworn it was raining outside. It was not. I had taken the visual, auditory, and temperature stimuli and integrated them into a momentary perceptual illusion and a false conviction. On the one hand, nothing could be more trivial, and I'm sure we create and revise these momentary false perceptions all the time. However, these phenomena have bearing on our experience as participants in the empathic spiral. For example, often I can maintain my inner balance while feeling my way into the emotional organization of another. However, there are times when I have felt agitated with full physiologic responsive of sweating, rapid heart rate, rapid breathing, and high anxiety. At such times, I have experienced doubt and diminished trust in my own self-centering and felt deep in my gut that the patient's experience of me may be correct. Such moments have at times meant my scurrying down the hall to ask my trusted, esteemed office mate for some reality checks. Well, it turns out that we are susceptible to distortions in our body self-ownership. Methods to demonstrate this involve creating illusions of brain processes about self-ownership. For example, on the left, the rubber hand experiment creates the illusion in which a subject begins to experience a rubber hand as her own, while sensing that the real attached hand is foreign. Another example is the body swapping illusion that you see on the right, where using virtual reality equipment and manipulation of multisensory inputs, researchers can produce the conviction and the illusion that another or an artificial body is one's own. When the subject is looking down, he feels like his head is on the mannequin. A third is the enfacement illusion, where a person viewing a face begins to see and experience it as more similar to their own, including making attributions that the other face is of a like-minded person. All these experiments use a method of synchronous stimulation to the real body as well as the artificial body part. The brain quickly adapts to experience them as part of the body self. The rubber hand, body swapping, and enfacement illusions all change a person's ability to integrate challenge a person's ability to integrate multisensory inputs from the outside, something called exteroception. When challenged with competing stimulation, the brain creates a holistic experience, incorporating the foreign hand or body to the extent that it can be measured with changes to one's own physiology. The real but hidden hand temperature begins to drop. These experiments shed light on the perceptual processes that produce the sense of ownership of one's body and how malleable that can be. Another set of experiments helps us understand this. Interoception, or the ability to sense one's internal states, things like heart rate, gastrointestinal feelings, our skin, our bladder, can be examined by asking people to attend to their inner states. The heart rate is commonly used because it's just a more straightforward indicator to measure than more general body sensations. And you can ask somebody to, without touching their heart, to sense their heart rate, and you can put a pulse ox machine on their finger and read what their heart rate is. People do this, it turns out, with various levels of accuracy, and this is termed Interoceptive Accuracy, or IACC. People with low interoceptive accuracy are more likely to experience the rubber hand illusion, while body transition or whole body transition or identification with another's face. On the other hand, people with high interoceptive accuracy are much less susceptible to body illusions. In other words, if exteroceptive signals seem to serve the malleability of body awareness, and awareness of interoceptive signals seems to serve the stability of the self, reflecting a psychological consequence of the biological necessity of homeostasis. Put another way, self-overlap overrises when an observer engages in the same emotion as the observed person. Interoception studies can play a role in enabling us to navigate the different degrees of social relatedness and contagion by allowing us to correctly attribute the origin of body and mental states to oneself and others. Taken together, these investigations shed light on both the stability and the malleability of self-identification. In the face of incongruent multisensory inputs, the brain will integrate them even if it conflicts with an external view of reality. There's not time to illustrate or tell you the methodology of the experiments in this brief time, but in this day of TED Talks and YouTube, watching fascinating work is really accessible simply by asking the Google to guide you there. So just a couple of final thoughts here about implications for clinical work. First, perhaps this under the hood of clinical process can generate some new ideas about therapy itself. Maybe it helps us to see more clearly that whereas the strength of dynamic therapies has been to articulate idiosyncratic meanings, however encoded within a developmental framework, it's the deconstruction of the empathic process into its component subsystems that helps us to see more clearly that the elaboration of these organizations of meaning and motive is necessary but not sufficient for the dynamics of change. For that, we also need to understand the hierarchically arranged complex system that supports the interactive negotiation or the process itself to account for these changes. And we do that through the reiterative interactive search we call empathic understanding. Second, what if what we are doing is constantly reading and update our read of another person through continuous monitoring and registering our states in relation to theirs. In other words, exteroception and interoception. So we are not just hovering in our attention to read the other. We are not simply two subjectivities. We are not a constant, and neither are our patients. Rather, we are a constant in one sense, and that's a good thing that we're reasonably stable or less disrupted than the person next to us, but it's also constantly shifting, continuously adjusting and updating, much like the way proprioception keeps us upright. We are two dancers activated at all levels of our fullest biology and psychology in each of us at all moments. There's a micro and macro level at looking at the process, from embodied simulation to stable and flexible self-other boundaries to ongoing consistent traits in us and in the other. There's a constant interplay between intensity of affect contagion, self-other differentiation, and helping behavior that is modulated by the interplay itself, as well as individual characteristics of the participants. What about psychopathology? For the most part, these studies of embodied simulation and interoception, when they do address pathology, they address major illnesses like autism, psychopathy, schizophrenia, and body dysmorphic disorders. But for our purposes in understanding our own experiences in an ongoing, affectively evocative process, maybe we can think about subtler things. This is where my experience in the kitchen might be relevant, or where we might look to rethink our understanding of these phenomena, such as projective identification, wherein we seem to adopt or merge with the patient's deep visceral experience of us, and we need to walk down the hall so our colleagues can bring us back to reality. Lastly, perhaps learning about the active searching process of empathic understanding not only helps us understand what happens in the empathic process, but beyond that can serve as a fulcrum to organize the seemingly diverse domains of our work. Maybe it gives us a way to order the common factors that we know underlie all therapies and to develop a cohesive theory that joins evolutionarily derived capacities of neurobiological systems with human encounters. So in the end, it's essentially this human process of conversation, engaging the search for empathic understanding that drives treatment, moves one person to new forms of emergent organizations. In this sense, the action of therapy constitutes therapeutic action. While we deploy the conversation for a special purpose of providing help, the process is not synonymous with helping or pro-social behavior. To work, it has to exist within a range and within a variety of conditions to serve as the agent of change. There has to be sufficient experience or imaginative activity to activate the process, but the domain of clinical process occurs in the space where differences in idiosyncratic meaning systems and forms of expression can be shared and compared within the context of salience, self-regulation, and self-reflection. And that brings me to an end. And again, I want to thank you all for coming into my study and hearing me out. Thanks to Yellowbrick and the Psychoanalytic Institute. And I also want to just momentarily offer feedback to the specific individuals who listened to this over and over and gave me very helpful comments that helped me revise it. To Virginia Berry, Carol Moss, Rona Knight, who's a child psychiatrist colleague in Boston, and of course, our own Jesse Beiner. Thank you very much.
Thank you. So I have one question.
At the moment. Okay.
Okay. So if people have questions, once again, you can send them through the question and answer button on the bottom. I have one question, Dr. Jaffe, that came through as you were talking about Panskep's 7 instinctual systems. And it's, how does grief fit into that? And I guess by extending that, what do you think about the display of empathy or the empathy spiral with respect to grief?
Well, as a Jaak Panksepp sees these things as subcortical neurally organized systems that have evolved over evolutionary time because they help keep mammals alive. So at that level, panic grief is in the domain of what we would think of as separation. That if you are off foraging, you're moving more distant from the caretaker. And so the biological response is panic, and the instinctual reaction to the biological response is move closer. Now, that's become part of our lexicon of attachment theory. And we use words, and again, this is why I have to be careful, that grief in all caps is merely a biologically evoked response. It's not a subjective experience. That's a much higher order phenomenon, but it is related because loss is a moving away, but so are panic disorders moving away. So is separation anxiety moving away. So it's a much more elemental brainstem expression that gives rise to these higher order things. So empathy has to, fundamentally, I emphasize searching and play, because if you want to get anything in the world, you have to go out to it. That's the foraging response. And if you are going to deal with the world, there has to be a back and forth of that. That's the play interaction. But there's no question that all of the other basic emotion systems are involved. Grief, panic, certainly one of them. But then so is rage, lust, fear. So, but that's, and that's the best, that's the answer that I can give you. And it also, just very briefly, it's why I emphasize that empathic understanding can happen with or without eliciting a desire to help. It's not built into the definition. In our work, it's functionally built in, but it's not intrinsic to what that means. People can be empathic to others and use it for the most horrendous evil known to man.
Well, there's another question, but that just makes me think of something I was thinking of as you were talking about empathy and sort of the empathy spiral. And in some ways it's an unfair question because it's complicated, but what thoughts do you have about when the expression of empathy, well, when there's negative countertransference or a projectile identification that leads to negative countertransference, and that in and of, and the empathy is really with the negative emotion?
Well, I want to go back to my original definition. Empathy, empathic understanding is not a state. It's a thing we do. It's a search, and that search requires a reiterative back and forth. That's what I mean by the search towards knowing, the feeling into. It's not a state. It's a thing we do. That can get disrupted. And that can get disrupted in ways that means I can't bear what's going on, so I'm going to withdraw. We call that countertransference. Or I can't bear what's going on, so I'm going to say, whatever you believe about me, I believe about it too. You think I'm a horrible therapist, you think I'm whatever, I agree, just stop hurting me. So we can collapse and join with another in that if the affect, if the intensity, but then the empathic spiral is then disrupted. It's the cognitive empathy that we like to think of ourselves being able to use operates in the middle ground, where we can hold on to our sense of ourselves even as we are immersed with another. And that's what these studies explore. Are there other?
Yeah, go ahead.
No, go ahead.
Okay.
I see what.
Yeah, there's several questions here. Can you speak to how our multiple theories fit with the fundamental explanation of what occurs in the therapeutic process? So I think this is a question about application. How does it matter what theory we might subscribe to?
Say that last sentence again. How does what?
How does it matter what theory we might subscribe to?
We need theory because theories give us a way to organize what we're experiencing. We can't operate unless we have some sort of a theory to organize our data. But we all know that therapists of various stripes have all kinds of ways of organizing their data. In fact, sometimes you can say that the kind of therapy that you're in is simply a function of how the therapist is organizing the information. Whether it's family systems theory or Freudian theory or intersubjective theory or attachment theory, those are all just classifications of phenomena that we use to help us navigate and understand what's going on. And they all have a developmental aspect to them. So we're all putting it in the context of what we know about a person's growing up and what we think about what that meant to them. So that's highly variable. But what we all do is have conversations with our patients. So this process is the way, in fact, we gather information that we compare and contrast with our models, and then try to use our understanding to make useful interventions. But the process is generic. It has no purchase or propriety by any theory. In fact, too much belief in our own models can actually shut off the process of discovery, right? I mean, we all grew up with, the being told not to have an Oedipus in our mind and go after search and destroy missions for the Oedipus that we put there, right? We all know that. But it turns out it's not just about classical Freudian therapy. We can make fun of any theory that way. I'm seeing that Erica raised a hand. I don't know how to respond to that. But what else do you have?
This question is from John Rosenfield. The previous question was from Erica. He refers to Lisa Feldman Barrett's How Emotions Are Made, and he was interested if you had a take on her contention that there's no stable objective emotional state, and how that possibly could interact with the therapeutic process.
I'm not sure. I don't really know what a stable emotional state. I don't know enough about that person's work, honestly, to be able to even define what a stable emotional state is. What I can translate it quickly into, if you think about everything about us is an emergence of a complex dynamic system in operation all the time that brings every cell in our body to every neural system to the integration in the brainstem and then the cortex, and then reiterated in the terms of interaction. And we do that reasonably stable over time, then you could say we have feelings, but they're always at some level being created and recreated in a variable way on the fly all the time. So I don't know from beyond that. What else?
And a question for you to comment on the idea that romantic relationships, or in romantic relationships, seem attached to care and not to lust. And just they wanted you to elaborate on that.
Did I say anything about romantic relationships being attached to care? I talked about sympathy and helping, but not specifically romantic relationships. I mean, once we get into what is love, it's a huge domain, and hopefully a rich love is a kind of useful admixture of all of the emotional systems as they evolve and mature over time. But I thought what I was speaking to was sympathy and helpful responses rather than just empathy alone.
Another question is, can you, let me see here, the difference between empathy and merger, or how the two overlap?
Well, this is where people talk about self-other overlap. And I would say that when we are participant observers, we have to be open enough to really resonate with someone at the deepest level without losing that it's ourselves. So there has to be affect resonance, interpretation of what it means to me, and the self-other comparison and perspective taking. When that's lost, we call that merger. And it doesn't usually bode well in relationships. And we know that in intimate relationships, one of the kind of paradoxical ironies is that in order to be most deeply intimate, you also have to be most secure in yourself. Otherwise, the balance is lost and relationships deteriorate. You know, I just want to tell you, I keep seeing people in the chat room and people raising their hands. And I know that you asked people to kind of communicate with you directly. Just a heads up, I don't know what to do with that.
Yeah, actually, and my screen doesn't show the hand raising, or I'm not seeing it. So I'm reading the questions that come through the question and answer.
If you're raising your hands, could you please send a message to Michael instead? Because then we'll know. Sorry about that.
No, thanks. Another question, is a basic thesis of your presentation that empathy is an action arising out of a continuously reciprocal co-creation of a nonlinear interaction?
Words. The answer is yes, but like most words, they have deep commitments associated with them. I do think of therapy itself as best understood within the general frame of complex dynamic systems, where synergistic things begin to happen and new forms of emergence happen through a complex set of principles over time. In that sense, it is created by two people, and so you can use the word co-created. But to me, and I don't know what this questioner believes about that, but to me, co-creation is also a code word for modern intersubjectivity, which is a mentalist approach to psychoanalysis, which suggests that the only thing that's going on is what the two subjectivities create between the two of them. And it tends to move away from a commitment to the biological foundations of what's going on in the room. And it's much more of a hermeneutic, mentalist, philosophical position than a biological-based position. But in the end, if there are two people in the room and they're both constructing something, that's co-construction.
Another question, can you discuss more about salience of a common experience and how that differs from an actual shared or related experience?
If you arouse in me if you're communicating to me sadness, and I just lost my father, I have an experience of sadness. It has great immediate salience to me, and it's very proximal in time. And if it's too intense, because I just in the middle of mourning, I can't bear that at the time I'm with you, then it's probably then it may get in the way of me being able to really understand what that sadness means to you. So it's highly salient, but meaning it's meaningful, and I've experienced it, and it's recent, so it's proximal. But then it's a matter of intensity about whether or not I can maintain myself while still seeing you. Michael, we just lost Michael.
Yeah, I was muted.
The Zoom got you.
This brings us to 8:30. I think it's time to stop. Do you want to pause, see if there's more questions, or it's a good time to stop?
Dr. Viner, what should we do? I mean, it's okay.
Why don't we take the last question? Why don't you look at the questions on the docket, Michael, and see which one might capture the broadest interest.
Yeah. I've gone through the questions on the docket, but I can ask another question that that we think about here a lot is, in the creation of empathy or an empathic field with a patient, what about patients who are so disconnected from their own emotional experience that, in a sense, that doesn't register, that's hard for them to register, especially verbally?
Well, the search is the search. We encounter all kinds of things along the way, including walls. So the art of the search is to engage people in any way that we can so that we can begin to bring them more into a tolerance of that which they are walling themselves off from. So what you encounter as you start the search, and this is what I meant by it takes two people to do this. And we don't know exactly what we're going to encounter along the way. We encounter all kinds of things along the way. We encounter vast chasms, we encounter walls, we encounter explosives, we encounter traps, we encounter gratitude, we encounter openness, we encounter relief, and we encounter all kinds of things hiding behind all other kinds of things. So the curiosity is to push that search forward. And then, of course, it is the art of treatment to figure out what to do with all that stuff when we encounter them. And like I tried to say in the image of two climbers, we're tethered together all the way. So sometimes we have to let our patients teach us what to do about that. But the search is the search is the point. That's what drives it.
All right, unless another question pops up in the next second or two, I think, that brings us to the end. Thank you. This was really compelling and poetic at times, I thought.
Thank
Thanks.
you, Charles.
Thank you. I'm really glad to have done it.
Good night, everybody.
Good night, everybody. Thank you.